The Palm Beach Civic Association's Healthcare Committee presents How Do I Know If I Have Heart Disease? It's the number one killer in the United States. Do you know your risk? We talk with two leading cardiologists about the warning signs, prevention, and testing information that could save your life. Out of all the diseases in this country, including cancer, heart disease is still the number one killer, according to the American Medical Association. And what makes that so poignant is that there have been many breakthroughs in medical treatments developed over the last 50 years that save lives. But not everyone knows about the importance of testing and warning signs. So what you don't know can hurt you. And that's why the Civic Association's Healthcare Committee chose this important topic. How do I know if I have heart disease? Joining me today is Dr. Ken Franklin, who graduated from Harvard Medical School. From there, he did a cardiology fellowship at the University of Pennsylvania, followed by an invasive cardiology fellowship. He currently serves as a clinical professor of medicine at Weill Cornell Medical College in the cardiovascular division. Dr. Franklin is part of the Civic Association's Healthcare Committee, and we're so happy to have you here today. Thank you for sharing your expertise with us.
It's good to be with you.
It's so surprising that with modern medicine in this day and age, heart disease is still the number one killer. How is that possible?
Too many Americans are not working hard enough on their risk factors. People are not working at maintaining a trim weight. They're not taking a heart-healthy diet, and they're not exercising enough. Also, many people go for screening tests for such things as breast cancer with mammograms, prostate cancer with the PSA, or colonoscopy for colon cancer or other tests for colon cancer. Yet, all those three cancers, in addition to every other type of cancer, does not add up in terms of mortality to the 700,000 deaths a year that occur with heart disease. So people should go for screening tests for heart disease, and many are not. Thirdly, I think many people are not aware of all the symptoms that can be due to heart disease, and if they are aware, they're not acting quickly enough on getting the symptom addressed diagnostically and treatment taken if it shows something abnormal.
Well, it brings us to the title of our educational video today. How do I know if I have heart disease?
Symptoms can tell you. Heart attack symptoms would include generally chest discomfort, usually a pressure or heaviness. Can be associated as well with palpitations, racing or irregular heart beating, with sweats, with shortness of breath, with dizziness, faintness. But there are atypical symptoms, or less typical, I should say, symptoms as well, things like nausea, fatigue. These tend to happen more often in women than in men. Also in men, if the heart discomfort radiates to another part of the body, it will more often be to the left arm. In women, it might be to the jaw, the chin, or the upper back. So those less well appreciated symptoms which happen in women may mislead the woman and indeed her healthcare providers at the ER. They're thinking this is a gastrointestinal or a musculoskeletal problem, delaying cardiac diagnosis with adverse outcome.
So we want to focus on testing today. What kind of tests can a person expect to get if they are going maybe for their annual exam with their primary care doctor?
I think for an asymptomatic patient, evaluation should start with the general physical exam. We can not only pick up heart disease sometimes, but identify cardiac risk factors to help prevent heart disease. Blood pressure is normally done. Hypertension is a potent risk factor for heart trouble. The pulse is taken or a stethoscope is put on the heart to detect irregularity of the heart rhythm. Certain arrhythmias like atrial fibrillation or atrial flutter confer a much increased risk of stroke, for example. Putting the stethoscope on the back and taking a breath, the doctor will be listening for lung sounds. Certain sounds can indicate fluid in the lungs, which happens with a weak heart, certain valve problems, heart failure. Moving stethoscope up toward the carotid arteries, you can listen for sounds that shouldn't be there. We call those carotid bruits, which can indicate narrowing in the carotid arteries. Obviously, a stethoscope on the chest will look for heart murmurs. There's a test called the ankle brachial index, the ABI. Your blood pressure in your legs should be higher than that in your arms. It's very simple to take blood pressure, not often done, but easy to do. Blood pressure taken in the legs, comparing it with the arms. If it's lower than that in the arms, or even the same, that could indicate cholesterol buildup in the leg arteries. Now, why am I talking about, when we're talking about the heart, cholesterol buildup in the neck arteries or the leg arteries? If your body's putting cholesterol in one vascular area, it's much more likely to be putting it in another one.
Interesting. So, for a person who is not exhibiting any symptoms, but they have a history maybe with their family of heart disease, will those tests be different?
With the physical exam, an EKG is normally done. EKGs can look for past heart damage. They can indicate thickening, normal thickening of the heart muscle, which can cause heart failure, and certain reasons for thickening of the muscle, some inherited diseases, can confer a risk of life-threatening arrhythmias. One thing that should be made clear, because I think it's a common misunderstanding, EKG does not tell you very much about your risk of heart attack. You can have seriously narrowed vessels, all three coronary heart vessels, and yet the EKG will look fine. It's good for arrhythmias, it's good for thickness of the heart muscle, and also some unusual abnormalities that can indicate high risk of some serious arrhythmias in the future, but not for predicting heart attack. Going on to the blood work, blood sugar is done. That's an important risk factor. Cholesterol testing is done, another important risk factor if those values are elevated. Kidney disease is a standard test that happens with physicals. People who have kidney problems are at increased risk of heart trouble. There are two tests that are less often done that I think should be considered. One is the HSCRP, high sensitivity C-reactive protein. It's a test of inflammation. If cholesterol is building up in the heart arteries, those arteries become inflamed. And that inflammation can be picked up by this blood test. It's a nonspecific test. Any sorts of inflammation due to arthritic problems, autoimmune disease can cause it to rise. But if there's none of that going on and it remains elevated over a couple determinations, that may be an indication of cholesterol buildup in the arteries. The other blood test I think that's not often obtained, and I think more often should be, is LP(a). Think of it as a very sticky form of cholesterol circulating in your blood. It tends to stick to the heart arteries and arteries supplying your brain, increasing your risk of heart attack and stroke 2 to 4-fold. There's nothing much we can do in terms of exercise or diet to affect that. It's largely genetically determined, but one would at least consider working doubly hard on risk factors and perhaps initiating a cholesterol-lowering medication at a lower cholesterol than one would normally. Beyond the blood work and the regular physical, screening tests for an asymptomatic patient for heart trouble could include, and I think sometimes should include, a carotid ultrasound. More sensitive than listening to the carotids for narrowing in the neck arteries, and will also tell you the degree that they're narrowed. Once again, if that's present, it increases the risk of cholesterol in the heart. The cardiac calcium score, in my view, an important test to consider for screening. This is a low-dose CAT scan, CT scan. Doesn't involve an IV, doesn't involve X-ray contrast injection. It's relatively low dose. When one talks about tests or any procedure in medicine, almost in the same breath, we should be talking about side effects. But the radiation dose is only that of maybe 2, at most 3 mammograms, and no one is getting calcium scores done every year. Mm-hmm. So it's considered generally a low-dose test. It should take about 10 minutes. It generates a number. And your number could be between 0 and many thousands. The lower, the better. It's not perfect. There's virtually no test in medicine that's perfect, but it's very good. If you have a 0 calcium score, your risk of heart attack over 5 years is only 1%. So that can be quite reassuring. If it's higher, above 300, your risk is substantially higher. In between numbers, between 1 and 300, it's in the intermediate range.
What tests can a patient expect if they're showing symptoms and they have a history of heart disease in their family?
If people are having heart attack symptoms, chest pain, shortness of breath, palpitations, dizziness, racing heart, perhaps sweats, perhaps nausea, the thing to do is to call 911. Get an ambulance, takes you to a hospital as soon as possible. There, they will almost undoubtedly do 2 tests. They'll do an EKG, and there are characteristic changes on EKGs with in the throes of a heart attack, and they'll do a blood test called troponin. Troponin is a test that looks for heart damage. If both of those tests indicate a high likelihood that these symptoms are in fact due to a heart attack, you'll be generally rushed or taken as soon as possible to a cardiac catheterization laboratory. There, an invasive cardiologist will pass a catheter from a blood vessel in your arm or leg up to the heart and take pictures of the heart arteries. Knowing that we were going to be discussing heart tests today, I forwarded a still image of a coronary angiogram. Perhaps we could have a look at that. Okay, this is a still image from a coronary angiogram. The catheter injecting the contrast agent to visualize the heart artery is in the upper left-hand corner. It's injecting dye, which is flowing down the artery from the upper left along the top in the middle and then flowing down to the lower right. And you can see the large extent of that artery supplying a great deal of the heart muscle. Shortly after the artery starts, you see a very tight narrowing. That's probably 95 to 98%. We would call that a severe coronary stenosis. That's bad enough to be causing a heart attack. Were it to close completely, the heart attack would be even larger. Then you would only see that stump up on the left side, and none of that, the rest of those arteries and all their branches wouldn't be visualized. The heart would be getting no blood at all, and that would be a massive, massive heart attack. And this is the reason that if you're having symptoms suggestive of heart attack, you want to get yourself quickly to a hospital so this sort of testing can be done. The risk of an angiogram is on the order of about 1%, but frequently in the throes of an acute heart attack, that's considered by the invasive cardiologist and the patient to be well worth doing. Symptoms other than heart attack can also tell you that you might well have heart disease. Symptoms such as exertionally provoked chest discomfort or shortness of breath, fatigue not attributable to other sources, swelling in your ankles or legs, or narrowing of your heart arteries, much less than in the picture we just saw, could also cause symptoms. Tests for mild or milder degrees of narrowing the heart arteries, but which can still cause symptoms. There's a newer test called a CT coronary angiogram. I like a lot. It's a CAT scan, but higher dose radiation, though not if it's done in a center with up-to-date equipment, the dose is not very high. It does involve an IV. It does involve X-ray contrast, and gives you images somewhat like that invasive angiogram, a bit fuzzier, not as clear, and doesn't show some of the smaller vessels. But in general, is quite a good test for diagnosis of whether symptoms are due to mild or moderate or even relatively severe blockages in the heart arteries. Stress tests are still often used and quite valuable for people who are having symptoms, particularly those brought on by exertion, such as shortness of breath or chest discomfort. The routine stress test, which is doing an EKG while walking on a treadmill, or adding, for more accuracy, a nuclear stress test to it or an echocardiogram. The nuclear stress tests, widely done in the past, they've been being done for 50 or 60 years, are being done less frequently. They do involve a fair amount of radiation, and there are a number of false positives. So the CT coronary angiogram is becoming more popular. There's another test called a PET scan. That test has somewhat more accuracy than the nuclear stress test and involves less radiation. For other types of heart trouble, problems involving the heart muscle, the cardiac valves, or the electrical system, there are other tests. For palpitations or racing heart, which can be very important. Again, it might be atrial fibrillation, raising the risk of stroke. Mm-hmm. If you're having symptoms and you can get an EKG done while you're having the palpitation, that will diagnose the arrhythmia. But frequently, that palpitation or racing heart may go on for a minute, an hour, a day, and by the time you have the EKG done, you're no longer having the arrhythmia, and the EKG looks normal. So devices like the Holter monitor that's been around for decades, you can wear it for 24 hours, will pick up any arrhythmia. There's another type called the cardiac event recorders, and that will record arrhythmias over several weeks and can sometimes be sent by telemetry to your doctor. Newer devices are wearables, things like the iWatch. Not to advertise for one company. There are others. If you're feeling something, you can tap it and it'll tell you whether you might be having atrial fibrillation. They are not 100% accurate. You need to show it to a physician. Lastly, in terms of long-term monitoring, there are devices that can be put under your skin and can be put there for many months or even years, which will detect arrhythmias. That's important for people having very episodic symptoms. Mm-hmm. And particularly, it's being used more and more in people who've had strokes. When the cause of stroke is not apparent. Atrial fibrillation and flutter are so common that even in someone who's never felt it, and they can be asymptomatic as well as present with racing heart rate, it's not rare to have the implant show that there's an arrhythmia 9 months later, for example. For heart murmurs that are heard on physical, or for some other cardiac symptoms, doctors often reach for an echocardiogram. It's one of the most widely used tests in cardiology, and for good reason.
The echocardiogram is very important. Let's learn more about the echocardiogram. It is just one of the many tools in a doctor's toolbox when it comes to diagnosing heart conditions.
This is a very easy test that we're going to do today to get a better understanding of how your heart is working.
Dr. Utpal Sagar, a cardiologist at Mount Sinai Heart, New York, in the Jupiter location, specializes in non-invasive cardiology which does not involve cutting of the skin. One of the tests he uses to help evaluate patients and diagnose heart problems is an echocardiogram, or echo, which uses high-frequency sound waves or ultrasound to create the images.
We're taking a look at the left ventricle, which is the major pumping chamber of the heart, and we're taking a picture of the heart as it beats and looking specifically to see the various walls of the heart.
One of the biggest advantages of the echocardiogram is the immediacy. The images are provided in real time, so doctors do not need to wait for results to come back from a lab.
You can see the function of the heart, you can see the sizes of the heart cavities, you can see the sizes and the function of the heart valves, and the appearance of various structures within the heart, whether they're supposed to be there or not. This allows us to understand if a patient has problems with blood flow to those various areas of the heart. If there is a problem with blood flow to those areas of the heart, then we may not see proper closure or contraction or movement of the walls of the heart.
The echo test can be used for patients who have no symptoms but may have a higher risk from inherited conditions, as well as patients who are symptomatic and very ill. It's a simple, safe, and painless procedure that provides potentially life-saving results.
I think that echocardiograms are a part of the initial workup that can be done to look at patients' overall cardiovascular health. And while it may not provide all the answers about a patient's cardiovascular condition, it can give interesting insight into some of the hints of what could be laying underneath their cardiovascular health.
And thank you so much to Dr. Sagar and his staff for showing us the echocardiogram. It was critical information for us to share. So that brings us to the question of when should people be tested? How often should they be tested?
I think people should be tested at least yearly at the time of their physical examination with the blood work, the EKG, and that we discussed. And if they haven't had a calcium score, I think that should be considered strongly. If people are having symptoms, it really so much depends on the nature of the symptoms. The underlying heart disease is hard to speak to. For an asymptomatic person who's had a calcium score in the past with no risk factors, I might repeat that in 5 to 8 years, or consider that. For someone with risk factors or family history, I might repeat it in 3 to 5 years. One thing important to know, and I think not well known about calcium scores, are that if you're on a statin, a blood cholesterol lowering medication such as atorvastatin, for example, or rosuvastatin, which are Lipitor and Crestor, that can raise the number in the calcium score, making it look like you're depositing more cholesterol when you're really not. So if I've had a calcium score and you're on a statin, that result needs to be interpreted quite cautiously.
What are some takeaways, a couple of takeaways that you want people to know when they watch this, when they're just going out to try to determine if they have heart disease?
If you're having symptoms that suggest heart attack, you call 911 and you get yourself by ambulance to the hospital as soon as possible. If you're having other types of cardiac symptomatology, call your healthcare provider and get seen as soon as possible. Don't discount palpitations, racing heart rate. They could represent atrial fibrillation and flutter, and you could be at risk of stroke. Number 2, go for screening tests. The general physical, with the blood test, the EKG, perhaps the Lp(a), the high sensitivity C-reactive protein that was discussed, and the cardiac calcium score. Thirdly, work on your risk factors. That will not only reduce your chance of having heart disease, but will much reduce the chance that you will need multiple cardiac tests or even invasive cardiac testing in the first place.
Excellent. And there's so much information on the internet. Do you have a website or a couple of websites that you like people to look at for more information?
Right. I think very well done websites on this would be Mayo Clinic's website, Cleveland Clinic's website, and the American Heart Association. When you go to those, type in cardiac testing or heart testing, and that should take you to a list of tests that can be done or are done, and some description.
Dr. Franklin, thank you so much for joining us today. We thank you for all the information.
It was a pleasure.
And we thank you for joining us, and we hope you can use all of this information to stay healthy.